The Sunset SPE looked into comparing head-to-head these two catheters, that is a standard multi-site hole catheter versus the ultrasound-enhanced thrombolysis. And the only reason this was done is because we've seen an explosion in catheter thrombolytic techniques, and in a cost-conscious health system, I think it really matters to check the finances of its intervention that we are doing. So the Sunset SPE compared head-to-head these two devices in patients with submassive pulmonary embolism. Our study, unfortunately, was not able to detect clinical endpoints. To use clinical endpoints, you really need hundreds, if not thousands of patients. But we were able to power our study using as an endpoint thrombus reduction. And that's the key advantage of ultrasound-assisted thrombolysis, at least in vitro. So we compared head-to-head the two devices, looking at thrombus reduction. And the ultrasound-assisted thrombolysis is 10 times more expensive. And if it really works by having a 50% increased thrombus reduction, we would expect lower TPA dose, we would expect a lower ICU stay, we would expect a lower hospital stay, and then it would really be cost effective. We didn't see that. We didn't see a change in thrombus reduction. We didn't see a superiority. And in the clinical endpoints, we also didn't see a difference. I think we are not done yet because ultrasound-assisted thrombolysis has a potential to perform in a very short period of 2 and 4 hours. We didn't test this standard multi-site hole catheter in a 2 or 4 hour setting, as this is not yet real-world practice. There is some data out there for ultrasound-assisted thrombolysis that can be effective in such short time periods. However, in real-world practice, this hasn't been tested yet. That's why this is something that needs to be seen in the future, whether standard catheters would perform equally good in these short time, 2 to 4 hours. Thrombolytic techniques are safe and effective in general. They can achieve quick thrombus reduction. They can achieve quick reversal of the RV dysfunction, and they can save our patients. And I think this is the key message, that thrombolytic techniques are here to stay. And we need to learn more, and that's what we're doing.